is an advocate for people with bleeding disorders, von Willebrands, and in general, women's health. Dr. Lavin is a great friend of our organisation, has spoken at many conferences and events. So I'd like to pass you over now to Michelle, who's just going to get her slides organised for sharing.
Great. Thank you so much, Debbie. And it's great to see enthusiasm for von Willebrand's disease, even at 7 o'clock in the evening. So thank you everyone for taking time out to have a look at what's new in terms of vWD with our guidelines. So hopefully everyone can see my slides. Can you see them there, Debbie?
Yes.
Perfect. Yep. I'm nearly expecting a Zoom technological disaster. It nearly doesn't feel like a meeting without it at some point. So today I'm going to talk about the new von Willebrand disease guidelines and look at how that influences treatment and care. Here are my disclosures. And I suppose it's important in terms of the guidelines to know who.
Trying to reduce the number of days that people are required to stay in hospital, and to do that, we need to have much more remote care for patients. So the journey.
I think everyone tried to.
Sorry, I don't know what happened there.
Yeah, I was sent back to Haemophilia land there, but I hope everyone will take me back in von Willebrand's world at the moment. So apologies for that. So in terms of the guidelines and why they're important is that we often get different guidelines coming from different organizations, and sometimes they can be in conflict with each other. So this is the first time that all the major groups internationally, the American Society of Hematology, the main international patient organization, the World Fed, the International Society on Thrombosis Hemostasis, the National Haemophilia Foundation, along with an expert methodological group from Kansas University, came together in order to actually devise a single guideline that could be used to help guide care for patients with vWD worldwide. So in terms of just to briefly kind of explain the background to the guidelines to hopefully give you some confidence in how they were developed, we had a really diverse panel. So there's about 20 people involved in both the diagnosis and then 20 people involved in the management side of the guidelines. And this was not just, scientists and clinicians. There was a very important emphasis on patient involvement in these guidelines. So we had patient representatives on both the diagnosis and management guidelines. And I was very fortunate to be involved in the management guideline itself. And they use this PICO structure, which I'll talk through, and an evidence to decision framework. But importantly, the manuscripts are freely available to all, so that it's not behind a paywall. They're available online and anyone can read them, but they are fairly weighty. So hopefully I'll kind of make them a little bit easier to digest today. In terms of how we developed the guideline, we started off and we were allowed only 10 questions for diagnosis and 10 for management. So it's really why we aren't able to go in depth into every aspect of von Willebrand's disease, because we had to pick what were the 10 most important questions. And this was framed by a scoping survey involving patients and physicians, looking to where was the biggest unmet need in terms of the diagnosis and management of von Willebrand's disease. And these all had to use a PICO format, so we had a structured approach, and that involved patients, intervention, looking at what comparison and what the outcome was deemed to be. And then following from that, we had a synthesis of the evidence. So thankfully, we had a huge methodological team that was involved in getting all the data that was currently available and going through at times over 1,000 abstracts per question, and really refining that down into the evidence that was relevant to answer that question to inform us how we should best care for patients. And then from that, there was an evidence to decision framework. So you can see these are all printed out if anyone wants to have a look at them to see. And really what that looked at not only was the evidence that we had, but also how that evidence was influenced by the resources that were available, how acceptable was the option to patients. So we could have something that there was a lot of evidence behind, but in fact was completely unacceptable to patients. Then that would not be used in terms of developing, or that would influence our decision in recommending that option for patients. And it took into consideration equity. Would this improve access to care for people, and people's values and preferences and how they would be willing to accept a particular intervention or treatment. Sorry, this is giving us a little bit of trouble. And then we came to the recommendations, and the recommendations were then based on this structure. And when we look at the recommendations, the choices, as I said, were strongly based around values and preferences. So we had scientific data, clinical data, but we also took into account what were the values that were placed on different aspects of care, what were particular patient preferences would be likely to be in a certain situation. And really, when it came down to it, probably one of the strongest factors influencing our decision was making sure that affected patients were not missing their diagnosis. So that if we had a situation where one choice could mean that perhaps somebody was missing out on getting a diagnosis or getting access to care, that was a hugely important aspect for us in order to really understand how that would influence our decision making. And in terms of other considerations, then we look into cost effectiveness, resource requirements, and health equity, acceptability, and feasibility. So it's quite a complex background to each decision. And in terms of the recommendations, then we had either strong or conditional recommendations. So why would it be strong versus conditional? Well, strong for us meant that patients and most individuals would want this intervention, and most clinicians would advise people to receive this intervention. But a conditional recommendation is that the majority would want the intervention, but some would want to consider whether this was a suitable intervention for them. And that was largely based on how much evidence there was in that area. And that, for clinicians, it would mean that different choices would be appropriate for different people. And it really focused on the need for shared decision-making with that individual patient. So it was a long process. We started in 2017 and we're at 2021 now and they're just out, but there was a lot of effort put into it. And thankfully we managed to get our in-person meeting. Our last in-person meeting was about 6 weeks before the first case of COVID in Ireland. So we just got in there in time. But it was a really interesting process to be through and to see how thorough it was. And really, the two panels, one looked at diagnosis and one looked at management. And it really looked at all aspects of diagnosis, from the initial consultation, the use of bleeding assessment tools to help refine that diagnosis or suggest testing, what assays or what blood tests we should be using, and the role of genetic testing in patients with von Willebrand's disease and different subtypes. So just to briefly touch on what the guidelines, what the different points raised by the guidelines were. Firstly, looking at bleeding assessment tools. So these are usually the first step in a patient journey to diagnosis. And I'm going to paraphrase some of the kind of questions that were sent. So should we use bleeding assessment tools to determine the need for blood testing to see if you have a bleeding disorder? And what the guideline recommended was that for people with a low probability of von Willebrand's disease, so somebody attending their GP or their gynecologist with bleeding, but doesn't have a family history or a known bleeding disorder in the family, well, then we recommended that, yes, the bleeding assessment tool should be used as an initial screening to help actually determine who should be referred on for further testing. And they really found that adult women have the strongest, the data supporting the use of bleeding assessment tools is strongest in adult women, because once you start to menstruate, that's often a key predictor of a bleeding phenotype or a bleeding disorder. And I think what's just important I want to highlight throughout this talk is that this data regarding adult women actually comes from the low von Willebrand in Ireland's cohort study, which many of the people here this evening may have had family members or may have themselves been involved in. And I think it's really important to highlight the work of the Irish patients in terms of providing data that can be then used to improve care, not only for women or for patients in Ireland, but actually for people worldwide. So my thanks to everyone who get their time and their blood to that. In terms of bleeding assessment tools, what about if the risk is different? What about if you've been already referred to a haematology service because there's concern about bleeding, or if you have a high probability because you've got a family history? Well, there they felt that you couldn't use a bleeding assessment tool to determine if you needed testing or not. Really, you probably needed to go ahead with the test at that point, but they were useful to document the severity of bleeding in a standardized way. So it's using it in a different way, but it really underscores the importance of using a standardized set of questions. So everyone's asking the same questions of people and that the answers are being recorded. In terms of the blood testing for von Willebrand's disease, a lot of the diagnosis section probably changes practice more for hospitals and clinicians than for patients. So this is an example of that. They've recommended if we look at von Willebrand factor function, we have lots of different tests, and they've basically suggested that the newer tests may perform better than the older tests and should start to replace them. So that's because the newer tests are more reliable and easier to perform, especially in laboratories that may not have a lot of complex hemostatic testing available to them. So this probably doesn't make a difference on the individual patient. Unfortunately, it doesn't really reduce the amount of blood we're going to take to do the tests. We still need to, take those blood draws, but it's just changing what we're doing in the lab. And if we look at this in terms of a case, if we have an 18-year-old girl and she's been referred to hematology because of heavy menstrual bleeding, and she reached menarche at 13 and has missed days off school, her periods are long, she has to change her pads very frequently on her heaviest days, and her mum had heavy menstrual bleeding too and postpartum hemorrhage, but she didn't actually she's never been diagnosed with a bleeding disorder. But what the new guidelines will mean that if you look at what your different options are, we'd actually recommend that because there's a family history of bleeding, they've already been referred out to the hematologist, that we recommend doing these newer assay tests and to do a bleeding assessment tool to document the severity of bleeding. But it differs from if you see the option A here, where the test would only be performed if the score is abnormal. That wouldn't be the case because this girl has already had a highest enough index of suspicion that she's been referred on to hematology. So there are more changes in our assays. Can we use blood tests to diagnose fast clearance? That's type 1C. And they recommended against using this propeptide to antigen ratio because it's not widely available everywhere. So DDAVP trials are still our gold standard for diagnosing fast clearance. And that's really, again, influenced by low availability, that it mightn't be equitable if we were to suggest that. For type 2 von Willebrand's disease, this is something that may make more people be diagnosed with type 2 von Willebrand's disease because they're suggesting a cutoff that's higher than we usually use. So we look at how your von Willebrand factor, how much of it there is, how hard it works. And if there's a difference between those two, that suggests you could have type 2 von Willebrand's disease. And because they've changed this, it means that you don't have to have as much of a difference between those two numbers to get tested for type 2. So more people might fall into this type 2 category, and we'll really have to see how this is influenced. In terms of genetic testing, because genetic tests are more widely available for certain subtypes, really type 2, so type 2A, or type 2B, type 2N, that they're recommending genetic tests over traditional laboratory tests, which often weren't as accurate and more difficult to perform. So I think this is kind of where maybe it's important for individuals with von Willebrand's disease. This question, can you outgrow von Willebrand's disease? If your levels are over 50 as you age, do you have von Willebrand's disease anymore? So now they've addressed this for the first time, and they suggest reconsidering the diagnosis, but not removing it, because this is important in terms of how people access care. In Ireland, you'll still be seen by a hematologist, you'll still be able to access care, but in some countries, if you say somebody doesn't have von Willebrand's disease anymore, they may not be able to get their insurance to cover von Willebrand related treatments or care. So actually normal levels, but we don't actually have evidence that as you age, if your levels go up, the bleeding will cease completely. So that's why it's important that people still can access their centre as they need. So what about the thresholds? So there's always this question about low von Willebrand factor, and we've done a lot of work on this in Ireland. So they've suggested that less than 30% remains as type 1 von Willebrand's disease, and people with levels between 30 and 50 and bleeding, that they're also calling them type 1 von Willebrand's disease in the guideline as opposed to low VWF. Now, this is controversial. This is probably one of the more controversial sections of the diagnosis. But again, it largely comes back to that we want to make sure people can access care. And particularly in North America, access to care can be difficult if you don't have a standardized diagnosis. And low von Willebrand factor is not recognized by many insurance companies as being something that is covered for insurance purposes. So that they are recommending the use of the type 1 von Willebrand's disease in this setting so that people can access the care that they need. So I think it's understandable, and the last thing we want to do is exclude people from care. In Ireland, we'll still be calling it low von Willebrand factor, or / type 1 von Willebrand's disease. I think it's important to recognise that people who have levels in this range behave somewhat differently to some patients with type 1 von Willebrand's disease, and that's why we're anxious to kind of make sure that we're looking at, you know, the individual in front of us and their condition, rather than creating one large group of people who actually have quite different needs potentially. So again, strongly influenced by access to care. Now we're on to the management section of the guidelines. Really, when we think about management, of course, you have general bleeding symptoms. Particularly nosebleeds can be very problematic, or dental bleeding can be problematic for people with von Willebrand's disease. Of course, when you have surgery, we need treatment plans and protocols in order to optimize care and reduce the risk of bleeding at surgery. Women will have additional challenges with postpartum hemorrhage, so bleeding after a baby is delivered, or heavy menstrual bleeding. And as people get older, there are those challenges associated with aging and bleeding. Different types of bleeding may emerge, such as gut bleeding, or the need for additional drugs to prevent things like heart disease that can interfere with your risk of bleeding. There are also different treatment options, such as tranexamic acid, which is a general hemostatic agent. So it's kind of a general assistance to help you stop bleeding, but it's really more for minor procedures, or in addition to either DDAVP or von Willebrand factor replacement therapy, be that plasma-derived or recombinant. It's important to remember iron replacement and the role of iron in people who have frequent bleeding, and hormonal therapies for women who may have heavy menstrual bleeding and don't wish to conceive at this time. So the management guidelines looked at all these different options, all these different scenarios, and we had a limited number of questions we could ask. So I suppose it's not surprising that the first question, the number one question we had, was relating to the role of prophylaxis for people with von Willebrand's disease. And I think when you look at von Willebrand's disease now, it's about 10 or 15 years behind haemophilia. Our number of studies are much, much lower. Our consideration of prophylaxis and that kind of history of prophylaxis is not there for von Willebrand's disease in the way that it is for people with haemophilia. And, you know, frequently, even if people start prophylaxis, they'll often slip back to on-demand treatment. And it's the same kind of conversations that would have had more than a decade ago with people with haemophilia, trying to, you know, talk about the benefits of regular prevention of bleeding as opposed to waiting until the bleeding occurs. So this is not surprising, because it's, you know, it's not really in the physician's mindset to think about prophylaxis for von Willebrand's disease. There's kind of a perception that it's not as severe as haemophilia. While that may be true for some people, for people with severe von Willebrand's disease or severe type 2s or type 3s, they can have significant bleeding that can really impact on quality of life. And again, it's not surprising because we don't have research in this area in the same amount that we have for haemophilia. So when we looked at the data that was available for this, the guideline panel recommended in patients with von Willebrand's disease with a history of severe and frequent bleeds, we suggested the use of long-term prophylaxis rather than no prophylaxis, and that the bleeding symptoms should be periodically assessed. And this is important because it provides additional support in a guideline for both physicians and patients, and to help influence payers to pay for prophylaxis in countries in which that is an issue. So really it's about improving access to prophylaxis for people with von Willebrand's vWD, with von Willebrand's disease. But when you look at the evidence, it's quite depressing, really. When you look at all the evidence of prophylaxis, in all the studies of von Willebrand's disease patients with prophylaxis, we have one randomized controlled trial. So one trial where they looked at prophylaxis versus a placebo, so giving somebody a treatment that was, you know, they were unable to tell the difference whether they were getting prophylaxis or placebo. We have 5 studies where they defined beforehand what they wanted to check between the period while the patient was on prophylaxis, and they looked at patients who had no prophylaxis for a period of time and then had prophylaxis. And then you have 8 studies that kind of look back on patients who had a period of prophylaxis and looked to see if there was bleeding differences between the two. So this is really, really depressing, to be honest. And you can look on the evidence decision framework, which goes through all these papers. I've left up the link there if anyone is interested. I'm sure these slides will be available online. So we're just so far behind when it comes to von Willebrand's disease, but it's great to see the Irish Haemophilia Society supporting people with von Willebrand's disease in order to try and help drive this forward internationally. So what about people with a milder von Willebrand's disease? Now, I don't like that term because if you have a lot of bleeding, you don't have a mild condition, you know. So, but who needs a DDAVP trial? So we use DDAVP primarily in people with type 1 von Willebrand's disease and low von Willebrand factor. So the panel recommended that if you have a level less than 30%, you can have variable responses. So you should still turn up for a DDAVP trial. And this is a bit of a nuisance because you take levels at before you have your DDAVP, you have 30 minutes to infuse your DDAVP, and then at 1 and 4 hours, and maybe other time points in between. But one really positive sign is actually adult patients with levels between 30 and 50 IU per deciliter can be presumed to be desmopressin responsive. And again, this finding and this guideline change is directly from the information from the Irish patients that were involved in the low von Willebrand in Ireland cohort study. So again, Irish patients have actually improved care. There's going to be every adult who has low von Willebrand factor who gets diagnosed from now on will not have to sit in that chair for the 5 or 6 hours to have their DDAVP trial because of the work and the effort put in by the patients in Ireland. So again, my thanks to everybody involved. As you get older, this often comes up. So what about if I have a heart attack? What about if my doctor wants to put me on aspirin? I've been told I can't have aspirin. What do I do? Well, if you need antiplatelets or aspirin, this hasn't really been addressed before in any guidelines. And it's been really on a case-by-case basis. So we look at the risks and benefits and discuss with the patient, along with their cardiology team or their stroke team, about what the benefit would be. And the guideline came out, again, there's very little evidence to support this, but it would make sense that in patients with von Willebrand's disease who have cardiovascular disease, who need to have antiplatelet agents or who benefit from their use, we would suggest giving the treatment over no treatment. So it shouldn't be a barrier to access care, but it's important that this is not made by a single individual. It's a shared decision with the patient involving their multidisciplinary team of physicians relevant to their cardiology or their bleeding disorder or their stroke team, whatever the case could be. And there's a number of good practice statements behind every recommendation. Because of the length of time, I haven't gone through them all, but I think this is important because it really highlights the approach we want to take. That you take a multidisciplinary team approach, that patients are provided with education about the risks and benefits. And for people with severe disease, they may need von Willebrand factor concentrate while they're on it. And again, you can't use desmopressin therapy in these people because that can actually cause problems if you have ischemic heart disease. So just sensible approaches. And this is something we're already doing on a day-to-day basis with individual patients if they come into the situation that they require antiplatelets or anticoagulation usage and they have a bleeding disorder. But just by providing that guidance statement, it's going to support other individuals worldwide to get access to care and not be denied it. Surgery is really unchanged, and they're recommending that you have to keep the levels up for at least 3 days after surgery, up to 14 days, depending on what the severity of the surgery is. They're strongly advising the addition of tranexamic acid, which may not be practiced routinely everywhere. It's used a lot we use it a lot in Ireland. And the monitoring is advising not only von Willebrand factor activity, but factor VIII levels. Some countries would only do factor VIII levels in the postoperative period. That's not our practice here. We've always done von Willebrand factor activity. But this guideline just reasserts that as the best approach to manage patients in that period. So again, if you have a milder form of von Willebrand's disease and you're having a minor mucosal procedure, they're also suggesting that you can give tranexamic acid alone, which is something that we would do here for endoscopies and the like. And but again, just providing support for people to make that decision and provide that treatment rather than over-treating people for a procedure. For heavy menstrual bleeding, this really comes down to, there's no one right answer how you manage heavy periods. And it depends particularly on whether the woman is trying to conceive or not, because you can't use things like the pill if you're trying to have a baby. So really, if you're thinking about having a baby, then the recommendation is going to be tranexamic acid over desmopressin. But if you're looking at using, if you're thinking at this time that you're not planning to have a child in the next couple of years, hormonal therapy or an IUD may be a useful alternative to you. So if you go back to the case we had earlier, the young girl who had heavy menstrual bleeding, what approach can you take? Well, Hormonal therapy is a great option. People will have very strong feelings about this if they've tried it and failed it before. Often they may not have used a proper pill that has a high dose estrogen to really control their periods. And tranexamic acid is particularly helpful for women with bleeding disorders. So this really favors those two approaches over desmopressin, which will be used more frequently in America. So she is doing very well, Our Lady, but then she's 25 and she's thinking about becoming pregnant. And she wants to know what is going to be different about managing labour and delivery now with the new guidelines. And in terms of one of the important questions people want to know is about spinal anesthesia and what's the safe level to perform spinal anaesthetic. And if the panel has advised, we were looking at, is our level of 50% adequate enough for spinal anesthesia, or do we need to consider a higher level? And there was no evidence to support a higher level. So we're recommending that women should have a level of 50 to 150, over targeting a higher level to allow neuroaxial anesthesia. So that remains the same, but I think again, it may just help women support that decision to have epidurals if they're suitable for it. And what about after delivery? And I think this is probably the biggest practice change. This is not something that is currently being done internationally, but looking at postpartum bleeding, we know that women with von Willebrand's disease are at high risk of having postpartum or bleeding once they go home, in particular secondary or delayed postpartum hemorrhage. And the recommendation is now favouring the use of tranexamic acid for women with type 1 and low VWF levels, and this would also apply to type 2 and type 3 ladies potentially. And this was a conditional recommendation. It was based, they acknowledged that there was low certainty of evidence. There was really only 2 studies that this was based upon. But the fact that you could have a major benefit in preventing bleeding and the impact that would have on individual women was deemed to be very significant in making that decision. And the low risk profile associated with tranexamic acid was also favourable to it. So this is certainly practice changing, and it'll be really interesting to see if we can impact and improve the postpartum period for women who've just had a baby with von Willebrand's disease. So when we look at Our Lady again, and she's wondering, can she have, is neuroaxial anesthesia contraindicated so she can't have it? Do we give it to a level of 50 to 150%, a higher level? Can we say you can't have tranexamic acid before thrombosis? Or do we say you give it because of the risk of hemorrhage? And now we can say that you should target to a higher level, and you should also give tranexamic acid in the postpartum period to reduce the risk of hemorrhage. So how does this change practice in Ireland? Well, I'm glad to say we were already doing a lot of the advice that was in this. There's going to be subtle practice changes in terms of diagnosis. There isn't going to be any major ones. We now have new thresholds for type 2 von Willebrand's disease. Excitingly, we've led the way in no DDAP trials for people with low von Willebrand factor, and that's great to see that adopted worldwide. For children, the responses can still be more variable, so children are still facing a DDAP trial. And postoperatively, we were still looking at the same monitoring that we would normally do. I think it's great that the guideline is giving more support for prophylaxis, and I hope that we'll see a change in attitudes towards prophylaxis from both physicians and also patients looking at uptake of prophylaxis in the coming years. I think cardiovascular disease, it's really emphasising an individualised approach for antiplatelet use, and postpartum tranexamic acid is a big practice change that hopefully will help bring down the risk of postpartum hemorrhage in women with von Willebrand's disease, which in some people, or in some studies has been recorded at rates of up to 30%. So it's hard enough having a young baby, never mind having bleeding along with it. I think what's really been fantastic throughout this is to see the impact of the Irish patients' contribution and the research and the effort that people have put in, and how that actually is translated to change in international guidelines. So a bula bus to everyone there from that. What about the limitations? Well, you're trying to cover 7 different subtypes of von Willebrand disease in 10 management questions and 10 diagnosis questions. We're hugely limited in von Willebrand's disease by the lack of research. And the guideline has no strong recommendations as a result of this, because we don't have, very strong, large studies involving lots of patients with von Willebrand's disease that can really tackle a lot of these questions. What are the benefits? Well, I think the benefits have been a collaborative approach between people with von Willebrand's disease, basic scientists, clinicians, and research methodologists. There's also been very important for identifying those gaps in research and understanding and really trying to target the community towards answering those questions. In patients or in countries where the access to care has been determined by payers, having more forthright statements can really help people access prophylaxis and care. So hopefully it will help people access care in countries where that's more challenging. It's been independent of pharma involvement, and for every individual involved in the panel, conflicts of interest are clearly stated and people were recused from voting on any question in which it could be considered that they have a conflict. It's also been brought together by multiple organisations with differing interests. So we have both patient organisations and clinical organisations, scientific organisations. So we have different interests but similar goals, and that's really to improve care for people with vWD worldwide. You can find these guidelines, they're freely available, they're very, very long to read. If you think this presentation is long, this is the synopsized version of it all, but they are widely available, and I'm sure there'll be links on the website. And in terms of having kind of more bite-sized chunks of the guidelines, the World Fed are going to organise a webinar. I'm very fortunate that the World Federation of Haemophilia have asked me to take on the role as the chair of the von Willebrand and Rare Bleeding Disorder Committee. So we are organising a webinar, hopefully for Tuesday, May 18th. I'm not sure if I'm supposed to publicise that yet, but everyone in Ireland can have a preview of the date. And it's going to be looking at discussing the impact of guidelines for people who have von Willebrand's disease. And finally, we also have a new exciting venture with EHAD and the European Haemophilia Consortium, and that's looking at principles of care for women with bleeding disorders. So there is an upcoming webinar on this if anyone is interested in sitting in. We'd be really anxious to get feedback from patients about whether these principles of care to try and improve care for women with bleeding disorders are hitting the spot or not. That's happening on the 9th of March. So if anyone is interested, they can go to the EHAD website and register for free. And with that, I think I'm finished. Thank you so much.